Good afternoon, everyone. My name is Paul Warren. I'm a program manager here at NDRI, the National Development and Research Institutes, and it's my great pleasure to take you through the logistics for this particular webinar to increase your participation and enjoyment. And I'd like to direct your attention to the control panel. If you want to close your control panel, click on this little box here, and it will actually make your control panel disappear. If you'd like your control panel to come back, just click on the box again, and it will return. During the course of this webinar, you may very well be asked questions, and what you'll want to do is go to this particular box right here. This is the question box. You can type questions in here. You can type comments in here. Also, during the course of this webinar, you may be asked to raise your hand. Click on this particular button to raise your electronic hand so the presenter will know that you have raised your hand. In the event that you experience any technical difficulties, I'd like to address your attention to this particular number right here. If you have any difficulty seeing or hearing the presentation, please dial this number for technical support. This number will appear on future slides, but for your own convenience, you may want to write it down. I'd like to thank our sponsors for this webinar, the Bureau of Justice Administration and American University, in partnership with the Training Institute and NDRI. And it gives me great pleasure to introduce Dan Griffin, who will cover Gender-Specific Issues for Men, Part 2.
Thank you, Paul. Thanks for the introduction, and thanks everybody for being here as well. I'm going to go through quite a bit of information. You are going to have an opportunity to ask questions. We'll have a couple of polling questions as well. And if you were not able to tune in to the presentation last week, I will be reviewing a little bit of that information. So I want to thank the Bureau of Justice Assistance as well, NDRI, for their help in setting this up, the technical support, the content support, and then also Carolyn Cooper in the Justice Programs Office at American University. So let's just start by saying there's a lot of ideas about men and men engaging in services, but I fundamentally believe that it's not that men don't want help or services, but it's often that we're not talking directly to men. And what I mean by that is that we're often not talking directly to their experience as men. So this little picture here of my family, my beautiful wife and my beautiful daughter, is our hint that we have a polling question coming up. So without further ado, if you would go ahead and open the poll, that would be great. And the question is, what is the hardest thing for men to express when they first come into treatment? Okay, and we can go ahead and close the polls. And share the results. Now, of course, this is not a hard and fast answer. Some people could say feeling sad would be an answer, but really, from my experience and from the work that we do, not feeling safe and then being able to communicate not feeling safe seems like not only one of the hardest things for men to be able to communicate, but obviously it also gets in the way of them being able to communicate any other of their authentic experiences. And it's often something that we don't take into consideration perhaps as much as we could or should when working with men. So what are trauma-informed care? Or what is trauma-informed care? last week I covered really the whole idea of men's services and men's treatment, but today we're really going to talk about men and trauma and how to fit that in, and what does trauma-informed care look like. So these are the 4 kind of core characteristics of trauma-informed services developed by Roger Fallett and Maxine Harris. And that is that they take the trauma into account into how the services are created and delivered, avoid triggering trauma reactions and or traumatizing the individual, adjust the behavior of counselors, other staff, and the entire organization to support the individual's coping capacity. What that means is that if you're taking the trauma into account, you're not just doing groups where you're able to work effectively with trauma and to help somebody begin to become aware of and even mitigate the symptoms of trauma, but that the entire organization is paying attention to that reality all the way up to the people who are greeting the individual and even the cleaning staff, that there's an understanding that in order for the environment to be very safe, it has to be organization-wide, and then allowing survivors to manage their trauma symptoms successfully. Many trauma survivors, unaware of some of the physiological and neurological impact of trauma, often feel as though they are victims or have no control or no ability to intercede on what's happening to them when they're being triggered or re-traumatized. And so it's really important to begin to give them some sense of not only self-awareness, but capacity to take care of themselves. Core principles of trauma-informed care. This goes back to that first polling question. These are the top 5, again, from Roger Fallett and Maxine Harris. And safety is number 1, and safety will always be number 1 and should always be number 1. If men and women don't feel safe, they're not going to be able to talk about what's really going on. That's particularly important when we're talking about problem-solving courts, because the criminal justice system and the court system is not always worried about safety, certainly not emotional safety. And drug courts, problem-solving courts can be, but have not necessarily received training in that. Then take it one step farther, and while we may be focused on safety for women, very often we're not focused on safety for men because we make assumptions. And one of the assumptions that I say we should always be making is that if men are engaged in your services, if men are coming into your services, at the core, at the beginning of that process, men feel unsafe. The assumption should be that men feel unsafe, regardless of their behavior, regardless of what's happening, that there's some degree of not feeling safe. So trustworthiness, that's another extremely important one, and that's really so that the clients can trust us, that they can trust the team, that they can trust that they're going to get fair treatment. There's a lot of research showing the importance of fair treatment and how things are done, but also that you're going to walk your talk, that you have expectations of them, and that you hold those same expectations for yourself. You expect them to be on time to group, then you should be on time to group. You expect them to clean up when they make mistakes or they do something, then you should be expected to do the same. Choice, collaboration, empowerment, those are other principles as well. Choice, of course, is about understanding that in a collaborative process, which is the next one, people really should have the ability to say, this works for me, this doesn't work for me, without them necessarily taking over their care or their treatment process, but that they have a voice and that they feel like they have a voice. When I was working directly with clients, I can't say how many times I heard people saying, well, he's just trying to run the show himself, or she just thinks she's going to write her own treatment plan. Well, from a trauma-informed standpoint, it's actually really important that the participant, the client, feel as though they have some say in that. And then that leads to, of course, empowerment. So there's a question, is there another way to view men's trauma? One of the things I talked about last week briefly, and that continues to be a major area that I focus on, is that men's trauma tends to be underplayed. It doesn't tend to be viewed necessarily as trauma, and I'll talk more about that. But not only that, it's that there's still so many myths out there about men and men's experience of trauma. The ACE study is really a very powerful study. I'm not going to go into at length this study, but one of the things about it is that it was really a major undertaking by Kaiser Permanente, which is actually a health HMO, and you know, they were looking at their costs that they were incurring for providing medical services or paying for medical services, but they wanted to see what the connection between childhood experiences and later engagement in services could be. And so the ACE study actually stands for Adverse Childhood Experiences. And so they looked at those adverse childhood experiences and wanted to see what the connection might be. From an anecdotal standpoint, any of us working in the field for even a short period of time know that this has major effect, but it had never been quantified. It had never been, you know, researched and evaluated and really been able to be proven to the extent that it has with this. You can see that it had 17,000 participants. You can learn more about this study on the resource document, which will be coming out soon. And the resource document is about creating gender-responsive and trauma-informed problem-solving courts, specifically for men. The major finding with the ACE study, though, was that on a 10-item questionnaire, if individuals endorsed 5 or more of those items, they were much more likely to have significant problems in their lives in the future, whether it's obesity, diabetes, addiction, other things, a lot of chronic diseases, but other health issues as well. The finding also was that there was a correlation to trauma and trauma disorders, and that's really why the ACE study has been so significant for our field. So trauma in the brain, we've learned so much about the brain in the last 20 years. In 1998, Alan Leshner, who was at that time the head of NIDA, wrote this seminal article calling addiction a brain disease. He spoke in front of Congress calling addiction a brain disease. And this was only in 1998, and that was a fairly radical thing for him to do. So it just shows how far we've come in only 14 years as far as really accepting the impact on the brain. And now we're learning so much more about trauma and its effects on the brain. What we know is that trauma disrupts the chemistry of the brain and can not only predispose people to alcohol and other drug use, eating disorders, self-injurious behaviors, and mental health problems, but we see the mechanisms that where those problems seem to not only lie, but even generate at the neuroreceptor sites at specific parts of the brain, that's where we also see trauma. So there's a very deep and intricate connection between those. And if you're familiar with any of the research on attachment by Bruce Perry, others that have been doing that work, when they show MRIs of young children's brains, you can see that the trauma that occurs in childhood can have lasting effects on brain development. One of the great things about the human brain, however, is how resilient it is, how creating new neural pathways can really help the brain to heal. We're learning so much more about what helps the brain to heal, and that's an extremely important part too. For many years, people thought that the damage caused by drug addiction or trauma was a life sentence, that somehow the brain wasn't going to be able to heal from that. But we know it's just much more resilient and regenerative than we ever thought. All right, which leads us to another question, and that is CBT is effective for dealing with trauma, true or false? CBT is effective for dealing with trauma. Go ahead and vote. Okay, we'll give you a couple more seconds. Let's close the poll. And let's show the results, please, Clyde. So here's one of the things about this question. It's not a trick question per se, but really what it's meant to do is to just get us thinking a little more critically about CBT. What I mean by that, and I'll talk more about it in a second, is that while CBT can be effective for developing some of the skills for dealing with trauma symptoms, we also know now the impact on the brain and where trauma affects the brain is not something that is going to be as responsive to cognitive approaches. And I'll talk more about that right now. So trauma and CBT, and when I do this presentation, people sometimes leave having heard me say that CBT, the cognitive behavioral therapy, is not effective for trauma. I don't mean to say that, so please, if that's what you walk away with, know that was not what I intend to communicate. What we do want to do, however, is we want to challenge this idea of CBT that's out there that says it's kind of being treated as the silver bullet, as the panacea, as the thing that everybody has to do. And while it can be effective, one of the things that we know about trauma is that when somebody is experiencing a trauma, triggering, being triggered, re-traumatization, is that the prefrontal cortex, the executive command center for the brain, is offline. In MRIs, if you look at MRIs and you look at the areas that are lighted up, you can see, looking at the brain, the prefrontal cortex, there's almost no activity going on in the prefrontal cortex. You look at the limbic system, which is really that primal, animalistic part of the brain from when we first developed as humans, and that thing is firing off. That fight or flight place, the fight or flight aspect of it that leads to freezing, where literally the reaction, the experience of the behavior is frozen in the individual's cognitive processes, limits the impact that cognitive behavioral therapy can have. Now, teaching somebody skills and being able to think through some things, that can always be effective. But if that's all we're doing with trauma, we're not going to be very effective. And right now, there's still this belief that cognitive behavioral therapy alone is an effective modality. Given the high incidence and overlap of addiction and trauma, we really just want the field to think a little more critically about cognitive behavioral therapy and how it fits within the overarching field and regimen of services. We also know that the trauma resides in the body as much as in the mind. And that's extremely important to keep in mind, too, because that's not going to be a cognitive approach either. And the field has been doing experiential therapies for a long time, or art-based, right brain-based therapies. Those have been shown to be extremely important in seeing one of the world-renowned theorists and practitioners of trauma, Bessel van der Kolk. I attended a 2-day seminar of his, and he said that one of the areas he's focusing on quite a bit is actually yoga. And if you think about yoga and what it is, yoga is about creating congruence in the body, it's about quieting the mind, and it's about breathing, being able to deeply breathe, which has incredible impact on brain waves and anxiety and that primal kind of limbic area of the brain. Now, when we talk about trauma, there's another aspect of this, and this is something that is just now starting to develop in many ways, and that is that trauma for men is different than it is for trauma for women, that how men experience trauma, how men respond to trauma, how men exhibit the symptoms of trauma-based disorders, how men heal from trauma. All 4 of those aspects are different than how it is for women. Does that mean that there's no similarities? Of course there are similarities. In fact, at some point down the road of their recovery, it's going to look very, very similar for men and women. But connecting with men, reaching men, being able to get men to be able to hear and look at trauma is going to be different for a large number of men than it is for women. And sometimes what works for a woman might work for a man, and what works for a man might work better for a woman. And the main thing is to just allow for that possibility and to be aware of it. Similar to what we did with women with the original paradigm of addiction services, we're now doing to men with trauma services. What I mean by that is that when addiction services first developed, across the board, men and women were given these services, and women were expected to have great results from them and really fit themselves into those services. What we're doing with trauma now is there's basically a feminine model of trauma work that's out there, and it's being applied as this generic model. It's been primarily written by women, normed on women's experience, and written with women in mind. Now, obviously, if we're talking about veterans and PTSD, that's still a very masculine piece. And interestingly enough, it's also endorsed, the primary ways of dealing with that are endorsed are CBT. So our whole thing is to say we can't deal with trauma without dealing with the gendered aspects of trauma. Just as we can't talk, we also have to talk about the cultural aspects of trauma. And of course also the way that trauma and trauma recovery fits into an overall system of care. Now, how do men respond to trauma? This is extremely important too, and I'm going to talk more about this in a second, but this does not mean that all men become abusers. I don't mean to say that, but what does happen, and we know it happens very much more often than many of the men would ever wish, is as young boys, boys are abused. They suffer alone with the abuse. Everything in the way that we're raised basically discourages us from talking about abuse, dealing with abuse, addressing abuse, getting support, being supported. And so a lot of boys and young men, and even men, suffer alone with abuse. And at some point, oftentimes in an attempt to reclaim personal power, they tend to identify with the abuser. And that means that many men become abusive. With their best effort not to, with really attempting to not do that. But one of the things, again, going back to this prefrontal cortex, is that if you talk to trauma survivors or people in recovery from trauma, they'll often say is like, I felt like I was possessed. I didn't feel like I could really control my behavior. And in many ways they couldn't. The cognitive functioning was not there. And so what you may hear from a lot of men who are abusive, who don't realize that they're actually acting out undiagnosed and untreated trauma, is that they feel crazy. They feel possessed. They feel as though something has taken control of them, very similar to addiction. All right, so that leads us to another extremely important polling question, and that is, it's a true or false question. Axis 2 personality disorders are some of the mental health diagnoses we know not related to trauma. Is that true, false, or I don't know? And go ahead and take a time to register your thoughts on that. We'll give it about 5 more seconds. Okay, why don't we close the poll and share the poll results. In some ways, I want to wait to give you the answer before I go into this next material, but the answer is absolutely false. And this next part of the presentation will hopefully really make that clear. But one of the things that we have to understand in general, when you talk to people who've been working with trauma for years, there's a man named John Briere, a trauma theorist who for 30 years has been banging the drum about trauma. And one of the things that he says is that if we dealt with trauma to the level and degree that it shows up in all of our clients' lives, if we did that on a regular routine basis, then the DSM-4, now to be 5, the DSM-5, the Diagnostic Statistical Manual mental health issues, that the DSM-4 would be a pamphlet. In other words, the symptoms and the ways that so many mental health issues mask the symptoms of trauma and the experience of trauma is absolutely critical to us understanding how to effectively work with people. So the process of trauma, I had that in my presentation last week. And one of the things that I wanted to kind of come back to is if you weren't on the call last week or weren't on the presentation, this is a really great schematic that I am going to give to NDRI and Justice Programs Office to share with others. It's a really good one to have during your staffings and during court and your individual sessions to just remind you about the process of trauma. But there's another part of that, and this is where the gendered aspect of trauma comes in. And when you look at these bottom three rectangles, squares, whatever you want to call them, what those are showing, and Dr. Stephanie Covington brilliantly put this together, but she has the area of retreat, self-destructive action, and destructive action. And you'll see some of the symptoms. Now, while not across the board, one of the things that we see is that very often women will fall into retreat, and very often men will fall into destructive action. Men and women might probably fall into self-destructive action in different ways. In fact, when you think of eating disorders, self-harm, we used to very often relegate that to the experience of women, that that's something that women struggled with. But the reality is that we now know eating disorders are much more prevalent for men. You know, once we stop making assumptions about what men struggle with and we create a space for them to talk openly and honestly about their experiences, we realize that body dysmorphia, disordered thoughts about body image, and eating disorders are extremely more prevalent with men, as is self-harm. It may manifest itself differently for men than it does for women. But the other thing that I'd ask you to really pay close attention to is the way that the symptoms of trauma, the behavioral symptoms of trauma, are manifested and expressed. There's retreat and there's destructive action. If for men, destructive action is one of the primary mechanisms that men externalize the symptoms of trauma, show that trauma is aggression, violence, and rage. That really has to have us question a lot about our courts, about how we respond to men's aggression and violence, about how we think about it. And it doesn't mean that by any stretch of the imagination that aggression, violence, or rage is somehow acceptable, that because if a man's been traumatized, you know, that that's an excuse. But it will give us a much better way of being able to help the man stop the abusive, violent behavior, as well as to do his own healing work. While the scope of this presentation is not to talk about domestic violence programs or anger management programs, what I can say is that a lot of those programs out there are almost destined to fail if they are not talking about men's trauma, and if they're not taking a trauma-informed approach with how they provide services, and if they're not bringing a degree of compassion to the men with whom they're working. I just want to talk about something, and that is, who is your least favorite, or if you're a masochist, your favorite female client to work with? And just think of that person in your mind. And anybody who's worked in the field for even a short period of time is likely to say that their favorite client or least favorite client is a person with borderline personality disorder. But what we also know is that the clinical features common in the diagnosis of complex PTSD are very, very similar to that of borderline personality disorder. Well, what does that tell us? It goes back to that question I asked earlier about access to personality disorders. We have treated access to personality disorders as if they're fixed, as if they're static. They're a life sentence. If you think of how you talk about people with borderline personality disorder, we even objectify them. We don't call them people with borderline personality disorder. We call them borderline. And we act with them, we interact with them, we treat them a specific way. As soon as you know somebody's got borderline, what's your prognosis for them? What's your diagnosis for them? How quickly are you trying to get them off your caseload? I've met therapists, of course, who love working with people with borderline personality, and it's a lot of those people who get that there's significant trauma. But if you look at the behavioral symptoms or the behavioral characteristics of borderline personality disorder, if you respond to those behaviors as though they are fixed, manipulative behaviors from a person who has this deeply embedded personality disorder, you're going to deal with that person a lot differently than if you view them as having complex PTSD and this manipulation, this push-pull, these common characteristics, these classic symptoms or behaviors of borderline personality disorder. If you view those through a trauma of lens, or a lens of trauma, you're going to treat them so much differently than you would if you thought of it as a fixed characteristic. And so really challenging the diagnosis of borderline personality disorder is significant. But this is where, really from my perspective, one of the most important parts of my presentation, particularly when we talk about the criminal justice system. And that is, if we're thinking of that process of trauma that I was just talking about, those lower three squares or rectangles, and we talk about the externalization of trauma, then what diagnosis for men would most likely mimic or mask the symptoms of complex PTSD? Well, when I ask this question, very often people get it immediately, and they say, this guy. This guy is also who we call antisocial personality disorder. And what if antisocial personality disorder and all the precursors or the antisocial personality disorder juniors, antisocial personality for kids, oppositional defiant, conduct defiant, explosive intermittent rage, what if all of those were also masking complex PTSD? We believe strongly that there is a high correlation with that. And if that's the case, what are we doing to men in the system? How can we be working effectively with them if the primary ways that we intervene with men who express antisocial personality disorder is with rigid structure, behavioral compliance, rigid behavioral compliance, but also this belief that they're broken, that they are unfixable, irreparably broken. We don't think that about people with complex PTSD. And the other thing that I ask you to think about is, let's think of the population. Let's think of the population of men that we're serving in the problem-solving courts. These are already men who have been marginalized. These are already men who are at a disadvantage from socioeconomically very often. So what does that mean? Well, what does that mean is these guys who already don't believe they have a voice, who already believe they don't matter, are given this diagnosis. And maybe they've been carrying a similar diagnosis since they were kids of oppositional defiant, conduct defiant. Oh, yeah, look at that kid. He's going to be antisocial. You better believe it. I can just see him in the prison system. Well, there you go. You've just sentenced that guy in many ways to that future. And that's how the system responds to people with antisocial personality disorder. We have to rethink how we're doing that, and we have to rethink how we are implementing that, integrating it, viewing it as part of the overall paradigm for how we're treating men. Universal precautions, we talk about universal precautions with the HIV and AIDS epidemic. Basically, when somebody was coming in, there was an assumption that said, because we don't understand this, we don't know how it spreads, because it's so easily spread, we need to treat everybody as though they could have HIV or AIDS. And that's exactly what we're saying about trauma. The incidence of trauma, particularly in the court system, the criminal justice system, the child welfare system, the juvenile justice system, the incidence of trauma is so significant, it's probably so high, that we have to assume that everybody coming in has trauma. And if you think back to the principles of trauma-informed care, or if you think back to what a trauma-informed environment looks like, there is absolutely no harm that can come to somebody who has not experienced trauma by being treated that way. It's just simply good care. So if we do that same level of care, if we do that same kind of good care, then that is really what we're talking about. And if you treat everybody coming into the system as though they have trauma, you're going to treat them a certain way. That doesn't mean that you impose upon them a diagnosis of trauma. You assess them, you reassess them, you pay attention, you support them, and when or if the trauma manifests, then you're able and prepared to deal with it. But rather than seeing it as something that might be there, having it as an expectation is really going to force us, cause us, and support us in dealing with trauma much differently in this population. So really it's about a paradigm shift of moving from asking what is wrong with you to what happened to you. Now we're also talking about engagement, engaging men. This is an excerpt from a presentation I created with Phil Breitenbuscher and the Children for Family Futures and the National Center for Substance Abuse and Child Welfare. And so engagement defined is basically the participation necessary to obtain optimal benefits from an intervention. So when we talk about speaking to men's experience, if we're speaking to men's experience, that's what's really most critical as a way to engage them. So it's an ongoing process beginning at intake and continuing through all services, engagement. It's responsive to changing needs and the situations of men. It enhances men's motivation. So rather than viewing men who are disengaging as not being motivated, not being compliant, particularly if you think of, again, the symptomology of men's trauma, men who are defiant, disengaged, apathetic, any of those things, if we read that as men being disengaged and possibly even exhibiting a lack of feeling safe, then we're going to do things differently. And it's a joint responsibility and collaborative effort. So you can see how the principles of engagement are very much aligned with trauma-informed care. Talking about engagement, and when we talk about engagement, it's about really looking at the services and looking critically at the services. What does that mean? Well, an agency walkthrough is one of the most powerful things that you can do for your program. And what that means is that whether it's a team member or somebody who works with the team or even somebody who's like a former participant, going through the process and giving you feedback. Courts, this is something that is used by NIATEX, a group out of Wisconsin that does improved processing for treatment programs. This is an extremely important and valuable tool that people can do fairly easily. Exit surveys specifically designed for men. And so instead of generic surveys, surveys that literally are asking men about their experience and their experience as men. The focus group of men who have been through your services, that's always important to do on a regular basis. Mentoring groups for men and their fathers. Alumni groups for former clients. As I work with problem-solving courts around the country, I hear more and more about developing alumni groups and 501c3s to really support the folks as they transition out of the courts. There's personal assignments, and then this is where people start to kind of get a little concerned. But really, it's asking these questions and being able to honestly answer them. But they're extremely important. So in the trainings that we do, on the curriculum that we've developed and the work that we do, we always bring this piece in. And people react to it in different ways. But the reality is if you're not willing to take a look at these questions, if you're not willing to take a look at these issues, you really need to question how effective you can be in helping somebody else. And again, I don't think that message is strong enough in our field sometimes. A personal assignment, and I would say this is one of the single most effective strategies you can use, and that's literally writing a letter to your father, or if you never knew your father, you can even write a letter to your father. I often hear, first time reaction by clinicians is, well, so many of the people we work with never knew their father. And I say, well, but they absolutely had a relationship with their father. Their relationship is built on the fact that there was almost no relationship there, but they have their judgments, their ideas, their perceptions of the man that gave them life. But there also are the father figures. There's also so many of the men who are fathers. So it could be writing a letter from your father that you never received, or writing a letter from your child that you wish you would receive. There are a lot of twists on it that can help you begin to look at your issues with men. But the degree to which you have done your work around your father and the degree to which you've done your work around your mother are greatly going to affect how you do your work with men and how you do your work with women. So I want to talk briefly about our curriculum. It's a little difficult for me to talk about the work that I do, the theory, all of the ideas without talking about our curriculum because there's a lot of people talking about trauma-informed, evidence-based curricula. But there is, and I really want to say this very clearly, there is no trauma-informed, evidence-based curriculum out there that's written for men. Our curriculum is as close as it gets. And while I often hear people saying, well, we're using this model or this model, and it seems to be working well enough with men, I say that's unacceptable, that we wouldn't allow that to be the case for women. We would never say doing women's trauma work with a male model is good enough, that we really have to look specifically at men's experience. So I was fortunate and blessed to be able to develop this with Dr. Stephanie Covington and my colleague Rick Dower. And it has 4 modules: self, relationship, sexuality, spirituality, very, very similar to Dr. Covington's groundbreaking Helping Women Recover in that regard. And there are 2 versions, a community and a criminal justice version. A lot of structure based on the principles of trauma-informed care. So a tight, consistent structure, predictable, letting people know a group ahead what's going to happen, introducing the group, and then after the group summarizing. Small group discussions are extremely important. Even if you don't use our curriculum or some of the work we're doing, if you want men to open up, one of the easiest things that you can do is simply create small group discussions. And when we say small group, we mean groups of 3 men. If you've got a group of 9 or 12, break them up into groups of 3 and then have them do some of the work you're asking them to do, and you will get a completely different degree of engagement and opening up. There are several other tools that we've developed for the curriculum. I don't want to go into all of that detail. That would be really another presentation. But all of it is trauma-informed and really our attempt to speak directly to men's learning style. The interactive lecture is a tool that we use that basically helps men. Basically what it is, it's when the men teach the material, which is a very interesting process, but it enables us to talk about some of the most serious issues with men. And those issues would be core to what we believe are part of a man's healing and recovery. Trauma, abuse they've experienced, and even abuse they've perpetrated, as well as homophobia and sexism. So I'm going to talk very briefly about each module. I talked a lot about this last week, and it's really the core of what I talk about, this idea that the therapeutic process is a little maybe incompatible with how men are raised. This dichotomy shows exactly what I talked about last week, and this tension between the rules for being a man and how men are raised, and not the rules for recovery, but the expectations for recovery. And you see the tension, you see the contradictions, you see what the challenges could be, but you also have to keep in mind that we're asking men to not only turn their backs on a major part of their identity, but a lot of these rules are really contradictory and counterproductive to healthy, effective relationships. But what's so important, and again, I talked about this last week, is that we look at men and these rules not as being fixed, that men never were sat down and said, hey, which of these would you choose? Which of these do you want? Which of these work for you? And that's a big part of the work in the curriculum, is asking men to really evaluate these rules and then choose the ones that they believe work best for them. Relationships, we've talked a lot about that, but really for us, relationships are core to the work that men have to do in recovery. Relationship with self, relationship with others, and relationship with a higher power. Now, when we talk about that, we mean all relationships, relationships with mother, relationships with father, relationships with family, understanding family of origin, but actual relationship skills, how to be in relationships. You know, we talk a lot of the times about men in relationships and imply and laugh about how they're inept and they can't do relationships. But the reality is that, and I've just seen this over and over again, it's not that men don't care about relationships, it's men that often don't know how to do relationships. They're not shown how to do relationships. In fact, men actually have no problem getting into relationships. It's being able to stay in the relationship and have a healthy, connected intimacy and vulnerability, because all of the qualities of an intimate and vulnerable and healthy relationship, all of those qualities are contradictory. Almost all of them are contradictory to how men have been raised and the rules for being a man. Sexuality is another piece, rarely addressed directly in addiction treatment. We talk around it. We do it in perfunctory ways, oftentimes because of our own discomfort. And then it brings us to our last polling question. And that question is, I think our program does an excellent job of addressing men's sexual health. And this is not to be critical of the work you're doing or the programs you have. This is really thinking about what role does sexuality play. So go ahead and vote. It looks like give it about 5 more seconds for people to vote. Okay, let's go ahead and close the voting, and then we'll share the results. And you know, I appreciate the honesty of everybody. I mean, when I worked in treatment, I would say we did a horrible job of addressing sexuality. A lot of the times if programs address sexuality, they do it as in like a Sex 101 sort of thing, you know, like they pull out a banana and they put a condom on it or something like that. But what we're really talking about is this full, all-encompassing sexuality and understanding how men are raised to see sex as taking place of so many other things. How men view women as a result of sex, how men view men as a result of how we're raised around sex and our sexuality. And oftentimes the discomfort with sex and the discomfort with dealing with sexuality has as much to do with us in our programs and our fear as it does with the individuals. In fact, there are programs out there with Dr. Covington's curriculum for women. There are programs out there that in jails and prisons say, well, we'll do your curriculum, but we're going to take out the sexuality module because we don't want these women who are in prison thinking about sex. And it's that kind of, maybe there's a good intention there somewhere. I mean, certainly it's safety that people are trying to think of, but it just seems counterintuitive. It seems counterproductive at the very least. And so obviously I have some strong feelings about that, but if we're not talking about sexuality and men's sexuality and really challenging men to look at the use of pornography, body image, masturbation, their fears around sex and being sex sober for drug courts, it's huge. It's a major relapsing factor for men. If we're not talking about sex with men and helping them learn and be able to express a healthy sexuality, they're going to get it the way that they've always gotten it, at least for the most part, and that's through pornography. That's through just kind of immature and limited conversations with other men. And men deserve much better than that, and their relationships do as well. So this leads us close toward the end of our presentation. I definitely want to leave some time for questions, so I'm going a little bit more quickly. I've already covered all of this piece, and I've talked a little bit about this, but I just want to say again that we believe that homophobia and misogyny are core to male socialization, and they're core, dealing with these are core to a man's recovery, that the male-to-male intimacy that happens with homophobia is so incredibly important. And this is not about men being homosexuals. This is about a more literal interpretation, and that's fear of men, fear of the same sex. And it puts an inordinate pressure on women to carry the emotional weight of a man's life. Spirituality, when we talk about spirituality, what we're really talking about is community, of men recognizing that they exist in a world that is bigger than themselves. It has nothing to do with religion unless a man decides that that's the case for him. And the court system and the courts in general, if you read appellate decisions, really don't get this, really don't understand this. And as a result, and particularly because of the advent of CBT, spirituality has been marginalized in a lot of programs. In our core belief is that spirituality is absolutely a core part of recovery, a spiritual transformation. And when we say a spiritual transformation, literally we mean men being able to see themselves in community and live in community. So we always get the question, is HMR, is helping men recover evidence-based? Well, it's based upon two evidence-based practices, and loosely based upon because it's women's, but helping women recover beyond trauma really were part of what inspired helping men recover. And those are both evidence-based practices. Now, we've developed it for men, but remember what I said, nothing like this exists previous to that. So, and it just came out in January of 2011. So we're in the process of getting it evaluated to become evidence-based. We do see an incredible result in treatment completion rates for the folks that have been using it and monitoring that. We've seen a 17% in the place where we first piloted it. They already had a pretty good completion rate of about 72%, but with the men who went through helping men recover, they saw it get as high as 89%. Another very great thing for us to be seeing is how many people are going for referrals for mental health services. Men are not only following through with referrals for mental health services, they're asking for more services. So that's my contact information. You can feel free to follow up with me. I do want to open it for any questions that you might have, any comments. Feel free to absolutely follow up with me. And I know that this presentation will be online so people can listen to it. I believe the PowerPoints will be available, and we've got the resource document that will be coming out. So I want to thank everybody who tuned in today, and please, if you have any questions, go ahead and type them out. So with that in mind, I again want to thank everybody for tuning in, and I appreciate your interest, and I hope as we continue to get this message out there that people really start talking about this and thinking about how we're providing services for men and engaging men in services. I will also like to thank NDRI again, and particularly the Justice Programs Office, Caroline Cooper and her group, for seeing this as important and valuable. It looks like we might have one question. First, outcome data on the effectiveness of this men's program to be available. Well, we are just now at the process where we're trying to set up a multi-site evaluation. So that's going to actually be some time, I think, before we see actual publishable results. But of course, as we're getting the data back, we'll be reporting supporting it with caveats and qualifications. But, you know, unfortunately, like I said, it's just getting going, and this is one of those things where we have to convince people to fund us, and in order to get people to fund us, we have to show them that this is important and this has value, and in order to show them that this is important and it has value, they always ask us to bring them data. So it's a bit of a catch-22, but we've got some really promising opportunities coming up. And here's another question. I'm sorry, I don't know how I'm missing these. Strategies for clients to form recovery relationships instead of romantic relations. Well, there's a couple things about that. One, and this might step on some toes, but I think the whole idea of fraternization and separating men from women in treatment, you know, constantly may not be as effective as we think it is. We create this complete relationship of resistance. If we were now, it doesn't mean that there shouldn't be clear boundaries or maybe even some separation, but at some point it seems that bringing men and women together could have some real benefit, particularly in healing trauma. But for recovery relationships, when men see the value of connecting with other men, when they're given permission to connect authentically with other men, when they can unwrap and disentangle all of their ideas about sex and how sex has taken place of so many other aspects of connection, when we talk to them about that, when we help them with that, when they can see that, that changes everything. That gets them to open their eyes and to begin to develop recovery relationships. For so many men, romantic relationships that they get into, they're attempting to meet a need, obviously. Sometimes they're acting out. Sometimes they're trying to fill, you know, some kind of space that's been created in the absence of their addiction. But a lot of the times they want connection. They want to feel good, and they're going to do what they know. And if our only thing we can say to men is don't get into a relationship in your first year, we're really letting them down. We've got to do a little bit better than that, and that's why we have to talk to men about relationships. We have to work with men around relationships and relationship skills and being able to communicate in a language of relationships and stop this foolishness that says men don't care about relationships or know how to do relationships. So I think we're out of time. If there's another question, I don't think I missed any of these other ones. Okay, what do you mean? Sorry, and I'm just seeing this one. What do you mean saying trauma resides in the body as much as in the mind? Are you speaking about cell memory or cell damage? That's a great question. What we're talking about is it's a little bit of both. What we've seen with part of where we get the idea that trauma lives in the body comes from Peter Levine and his work on trauma, and actually watching and observing animals who are in the midst of a flight from, you know, an attacker or predator, or even like a bear running from being tranquilized. When they come to, like a bear who's running gets tranquilized, when it comes to, oftentimes what it will do is it'll be still in the middle of that running, and it literally needs to shake out that experience out of its body. I mean, you know, if you think about when you're moving, when you're running, all the things that are engaged, your bones, your muscles, your respiratory system, your visual system, all of that, that's what we talk about when we say trauma lives in the body, because all of that is affected when we experience trauma, and it's all affected as the trauma goes undiagnosed. And so what we simply say is you can't just deal with somebody's brain and miss the body. So it's body memory and cell memory, but it's really just moving us away from thinking that trauma is just in the brain or just in somebody's mind, that there really is a physiological reality. But thanks again, everybody, for tuning in, and really appreciate your interest, and take care. Bye-bye. Oh, and Don't forget to complete the survey for today for participating. We'd love to hear your thoughts. Thanks so much.